Good evening, madam.
Good evening.
Good evening, madam.
Good evening, Sheila madam.
Can we begin with your
Good
permission?
evening.
Can we start?
Yes,
sir.
So good evening, everybody. Welcome to this month's episode of the FOGSI ICOG Guru Mantra series. This is a series which has been ongoing since the past 4 to 5 years. I remember it was done during Parag's tenure as well, and it was very well received. In fact, we have had excellent audience for the past episodes of the FOGSI ICOG Guru Mantra series. This is where we have senior stalwarts of OBGYN, including past presidents of FOGSI, past chairpersons and secretary generals of ICOG, who join and they share their knowledge, their wisdom. I remember so many legendary figures who have graced this dais. And today we have two more senior students, Dr. Narendra Malhotra sir and Dr. Pramila Modi, both of whom will be imparting a lot of knowledge and wisdom over the next 1.5 hours. Dr. Malhotra sir has sent his apologies. He'll be a little late because he is delayed in an emergency at the hospital. And Dr. Pramila Modi has very kindly consented to speaking. So welcome everybody on behalf of FOGSI ICOG. I would request our chairperson, Dr. Sheila Mane, who has joined, to give us a welcome.
Good evening, everybody, and my pranam. Pranam to Madam Pramila for accepting our invitation and also suggesting me and saying that this is the breastfeeding week national and must talk on breastfeeding. So that is so thoughtful, madam, and I know seniors like you will always guide us for that. So I welcome you to this Guru Mantra program. As Dr. Pratik Tambe already mentioned, we always look forward to hear from the seniors and learn from the seniors. And first time when I invited you, I still remember the Guru Mantra that day. You told me over the phone, and it's there still ringing in my ear, I think, those words. And today I have an opportunity to see to it that yourself you are there for this Guru Mantra program. So waiting to hear you, madam. Thank you.
Thank you. Can I start?
No, Dr. Sneha Buyar will introduce you, madam, I think.
Okay.
Dr. Sneha.
Everyone's been working day and night for
So we have two chairpersons for this session. We have with us Dr. Sneha Buyar, who is well known to all of us. She's worked extensively for FOGSI and ICOG in the past, and it's wonderful always to have a good academician like her who's part of this FOGSI ICOG Guru Mantra series. We also have with us our past chairperson of ICOG, Dr. Uday Thanawala. He's also a past vice president of FOGSI, and he's done a lot of work in the field of gestational diabetes. He's part of the PCOS Society as well. And the annual conference of the PCOS Society is, of course, next weekend where the new president takes over. We also look forward to seeing Dr. Uday at the ICOG annual conference, 22nd and 23rd of August in Bangalore. And Dr. Sheila Mane and myself are there, of course, to welcome all of you. All of you who have joined here, please register ASAP. And we look forward to seeing all of you in large numbers at the conference and at the convocation as well. Gratitude to our ICOG Governing Council members who have joined. Dr. Kanchan Prasad, I saw her a little while ago, and Dr. Anita Rajoria, please drive safe. You're in a moving vehicle, I see. Can I hand over the session now to Dr. Sneha Buyar and Dr. Uday Thanawala to further conduct the proceedings?
Thank you so much, Dr. Pratik. A very good evening to one and all. Indeed, it's a privilege for me to introduce Madam Pramila Modi. And for this, I thank Madam Sheila Mane, the ICOG chair, and Dr. Pratik Tambe, the secretary of ICOG, for having this session specially, during this World Breastfeeding Week. It's my privilege to introduce Madam Pramila Modi, who is the senior most obstetrician from Patna, who is blessing all of us. But just to complete the formality, she was the vice chairperson of 57th AICOG 2014 Patna, and she was the scientific chair as well for AICOG 2014. She is the past contributor, rather past president of Patna OBS Gynae Society, and has lots of publications and awards and accolades to her credit. I'm sure the talk on this subject by such a senior obstetrician will definitely be eye-opener for all of us. Even though we obstetricians feel that, we are the first person to, take care of and talk about breastfeeding, maybe we feel that we are so busy that we cannot, conceal the mothers antenatally, or maybe we cannot give adequate time for them to support the patients, or maybe the training to the paramedical staff as well. But I think if we consider the statistics, I'm sure Madam going to talk exclusively on this in details. So I'm not going to take much time and straightway hand over to Madam Modi for her speech. So we're eager to listen to you, Madam. Over to you. Thank you.
Thank you so much, Dr. Sneha. Respected President FOGSI Dr. Bhaskar Pal in absentia, Chairperson of ICOG Dr. Sheila Mane, esteemed office bearers. There are so many office bearers. I think many more will be joining us also. At the very outset, I congratulate the type of this event. I have never, attended like a Guru Mantra. And I thought some Guruji will come or what so. But then I understood by myself that people who speak are probably, they think that they are Gurus, whether yes or not, I don't know. So, a very good afternoon, good evening to one and all. Dr. Sheila Mane has given me this opportunity to just participate in the Guru Mantra session. I was really eager to. I chose to speak on breastfeeding because Breastfeeding Week is being celebrated globally from 1st to 7th of July, as you all know. Breastfeeding is not a new topic, but still we need to address about its importance in a big way. Coming to the topic, so the topic is importance of breastfeeding. Theme of the Breastfeeding Week for 2026 is breastfeeding for a sustainable start in life, strengthen what works. Now, incidence of breastfeeding in India. India's latest National Family Health Survey shows mixed trends. Early initiation of breastfeeding within 1 hour of birth has risen to 50%. That is really so good. But while exclusive breastfeeding for the first 6 months has dropped to about 56%, here we have to bring awareness and work a lot. Counseling for facilitating breastfeeding, there are some points. Best time for counseling the mothers is antenatal period. We are all doing it also, and it is the very important point. We have to inform all pregnant ladies while they come for the antenatal checkup that about benefits about breastfeeding to both mother and baby during antenatal period itself. Antenatal classes, as we have been hearing since long, the classes must be held for the expectant mothers and family members as well. It's not 100% that it is going on. Now we have to check for the status of nipples, most important, or any other pathology that is existing before pregnancy or even during pregnancy. Importance of healthy, nutritious diet, yoga, exercise, and all these things are just to avoid anemia. You remember, long back, there was a slogan, anemia chala jaye. Gaya kya? Nahi gaya. Anemia abhi bhi hai. So these are all interrelated ones. Skin to skin contact between mother and baby immediately after birth within first hour of life is called the golden hour. It is something, a new name, and it really works if it is followed. As baby's suckling reflex is most active and baby is alert in the first hour after birth. We have to show the mother how to breastfeed, including positioning and latching. Latching is very important. Breastfeeding on demand is really needed, day and night, anytime on demand. Exclusive breastfeeding means not to give additional food or drink, not even it is said that not even water to be given to the baby unless medically necessary for first 6 months. Now, the counseling for facilitating the breastfeeding, what we can help our patients is having the posters, handouts, short documentaries in the local languages. Suppose the documentary is in English and it is Bihar, not and many people will understand. So it should be done in the local languages, etc. To be displayed in the waiting hall, they can understand and maybe ask some questions if any. Artificial pacifiers is used so badly, which should not be given. We have to train all our healthcare staff to learn the skills for convincing the would-be mothers, address common concerns and myths about breastfeeding. We can connect many patients, not patients, the pregnant mothers, to their peer support groups. They can talk from each other and also gain confidence. Lactational consultant, truly speaking, last week only I could know, for the first time I heard that there are lactational consultants in India and they can really help if needed. Now, address cultural beliefs and practices that may discourage breastfeeding, how bad it is. The cultural beliefs that we follow and the practices that may discourage breastfeeding, which is a common occurrence in many places. For example, I should say, many a times, first breastfeed is delayed by the Panditjis, not us, Panditjis, to find good muhurat, like it is as though it's a marriage. So it's like a good muhurat, they want to just keep the baby on the mother's breast with a muhurat. It's wrong. Another thing is Janmaghutti. I don't know, you people from Maharashtra and other places, you do it as a thing. But here, Janmaghutti is very essential. The moment baby delivers, some elder person in the family, like a Dadaji or Nanaji, they will come and put a drop of honey on the tongue of the baby. This is also should not happen because the first feed always is a mother's milk and that is Amrit. It is said and we have to believe it. Now, tradition to, reciting a Guru Mantra. Sheila, I am just purposely I have told because I wanted to spell the word Guru Mantra. Because gurus, they just have some Guru Mantras in the ears of the baby, though, however, it is not related to breastfeeding at all, but whether it is going to do any help, I cannot understand. Now coming to some photographs. Breastfeeding, the positions are very important. There are very easy the positions, cradle position, cross cradle position, football hold, then laid back position and side lining. All these are very comfortable to the mother and also to the baby. So this must be taught to the mothers that you are sleeping and the baby is just taking the milk. It's all wrong. She has to be awake and catch like this. This is the positioning. Now, benefits for breastfeeding for mothers. Aids to involution of uterus, which results in avoiding PPH. It is so important. Still, mothers are dying due to PPH. So we can, if we follow these simple things, we can avoid PPH. Long-term breastfeeding helps to lose, it's the loss of excess of fat. Somebody told me that I lost my weight. So weight losing is very difficult, I know. So if the mother loses the weight, and she has really done it. Prolonged deep breastfeeding prolongs an ovulation, hence acts as natural contraception, but mind you, not in 100%. Documented long-term effect of breastfeeding includes to reduce cancer of breast, ovaries, endometrium, lowers the risk of type 2 diabetes, osteoporosis, hypertension, and heart disease. Other benefits are bonding, which is very important, bondage between mother and the baby, bonding with the baby, and convenience. Here I would like to say that breastfeeding has got a lot of convenience because neither the milk has to be bought from somewhere. There is no adulteration that is going to happen. It not to be warmed, and it is so easy. Like it is needy. It is very important that the mothers should feed the babies and remember all these things. And last of all, पैसा तो बहुत जरूरी होता है ना, and everybody's status is not the same. Costs is there. Potential protection against depression. Benefits for the of breastfeed for the baby. Complete food for the baby as it has all the essential food components required for growth and development in quantity. Helps to gastrointestinal development and function, and also immune system. Cognitive issues are also there in the infants. Breastfed infants have reduced risk of obesity. This is once again a good thing, good point. Later in life, not immediately. And compared with the formula-fed infants, so they have the opportunity. Reduced risk of sudden infant death syndrome, Hodgkin's lymphoma, leukemia, or type 1 diabetes. Lower risk of infections like otitis media, lower respiratory tract, which is very common. Infection, diarrheal diseases, allergies can happen, eczema, meningitis, and inflammatory bowel diseases. All these can be avoided. Hence, early maternal and infant bond is also very important in life. Now, the guidelines for adequate milk supply. Mother should be assured that the milk supply is adequate. If she asks, that means she's anxious and she thinks that the breast is little more. So, if average feeding frequency is 8 to 12 times per day, it's okay. Steady weight gain, it's okay. 6 to 8 wet diapers on an average per day. From second week onwards, the weight 500 grams to 1 kg of it is a gain and each month. If milk supply is decreased, the signs and symptoms are dehydration, which we can easily diagnose. Less than 5 wet diapers, baby is lethargic, inconsolable, unchanged. This is also important. Unchanged stool color by day 5 to bright yellow. Now, some causes of low milk supply. Supplement for formula feeds, interrupted or delayed breastfeeding, breast engorgement, very common, and not that easy to even manage. Breast engorgement, mastitis, and nipple pain. Mother-baby separation is not to be done. Mother is in one room and the baby is somewhere else, somebody else is tackling. This should not be done. Let the mother do all the things. Breastfeeding issues like nipple pain and mastitis, this is very painful. Faulty techniques of breastfeeding, psychological concerns, etc. Now, preterm infant, they have a problem. Oral and facial anatomical defects. You can see a beautiful picture here. Both together, cleft lip and cleft palate. How difficult it is to manage. So anatomical defects like tongue tie, cleft lip, cleft palate, Here what happens is airway problems like laryngomalacia, this happens. I have never heard it also and seen to bahut dur ki baat hai. Search the picture and really unfortunate. Hyper or hypotonia. During inhalation, laryngeal tissue above the vocal cords collapse into the airway, causing obstruction and struggle. Management of milk supply management of low milk supply. Assess and increase the frequency of suckling, correct position of baby, and proper latching, which is most important. So many times we speak about it, is to be ensured. In case the baby is unable to latch on, milk should be regularly expressed by hand or by the breast pumps, which are easily available if necessary. Now, some galactogogues, definitely they do help. And those galactogogues are botanically, in Hindi, it is kala jeera, dhania ka beej, methi ke beej, and drumstick, that is sahajan, and shatavari, everybody knows about it. And fennel seeds is the soaf, which we also take. So this is so easy and simple to get these things, not difficult. It's not a medicine. It's a herbal thing. Now, pharmacological galactogog are the other, not many. Domperidone is the only drug studied, and the dose is 10 to 20 milligrams. Supporting for breastfeeding in working women, it's a big problem nowadays. Women are working. I'm so happy to see young girls married. They join the banks and offices. But what is going to happen if she has given birth to a baby? So they come to us, they ask us. Lactation rooms should be there. It is all should be. Whether it is there or not in all offices or bank offices, it is there. But ideally, lactation rooms, flexible times for express milk time should be given. Options to work from home, that is very easy. Extended maternity leave, support at home is very important, especially by the so-called mother-in-laws, and my dear brothers, husbands also need to give a good support. Now, storage of express breast milk by refrigerator, in pantry in the offices, personal mini fridge or cooler bags. Purposely, I have given this photograph because I have never seen a cooler bag. But the Google ji to hai batane ke liye, so he has shown this picture. I'm so happy to have it. Storage of expressed breast milk, the rule of 3 has to be followed. And it is there, it is really there. At room temperature, the milk will be all right. In up to 3 hours, in the fridge for 3 days, and in the freezer, it is for 3 months. I was astonished. Any milk can be kept for 3 months. Anyway, I have no comments about it, but it is mentioned in the literature. Inability to latch. Golden hour must be used, and the baby becomes active in the first, as I said, golden hour, and then inability will not be there. Mother-baby separation, I dealt it. Maternal factors like position, attachment, nipple problems, large breasts, very, very large breasts, sometimes hanging, the baby cannot take in the mouth. There is congestion. Assistance is required sometimes. Infant factors, preterm, structural anomalies like I told you, tongue tie, birth injuries, asphyxia, etc. This is the beautiful picture of correct latching. How should it should be latched? Now, advantages of aspiration, because these are certain problems down below. Breastfeeding, breast abscess, sore nipples, and inverted nipples. Coming to the breast abscess. Previously, we used to drain, or every time, if not, it is getting treated. Drainage to break all the septi, we used to do. But now, we should learn and know that drainage of the breast abscess has to be undertaken many a times if necessary for big collection of pus. It is minimally invasive, avoids hospital admission, avoids baby mother separation, avoids painful dressings, cosmetic outcome is better and easier to continue breastfeeding. Now, current recommendation about this inverted nipple, I'm telling those syringe, cut it and then bring it out when we see the patient with the this type of nipple. We used to tell the patient, but no, the current recommendation is not to handle the nipple at all because it may irritate the uterus. Guidelines for breast milk feed for preterm baby or low birth weight. Breast milk is particularly important for preterm and low birth weight babies as well, as it provides complete nutrition. We should not wait for discharge and then introduce it as early as possible if feed tolerability is present. So, it is the gold standard of care of the preterm babies by giving mothers milk, because preterm babies who are fed mother's milk have less incidence of necrotizing enterocolitis, late onset sepsis, RDS, retinopathy, less need for ventilation, better neurological outcome, and lower mortality rates. To come up to the summary, breastfeeding is essential for mother who delivers either vaginally or by cesarean, whatever. It is very important to latch the newborn baby during the golden hour because baby is very active in this period. Proper positioning and latching has to be properly followed. Antenatal counseling is the best period for counseling about breastfeeding. Advantages of breastfeeding are for both mother and baby. This has to be told several times to the mother and the family members too. Expressed milk can be stored in refrigerators, as I have told you already. Storage of expressed milk at room temperature. Not that everybody will have a freezers or refrigerator. So room temperature also is there, but only for 3 hours. Likewise, refrigeration for 3 days and freezer for 3 months. Nipple care must be taken positively in every antenatal checkup. For preterm and low birth weight babies, the gold standard of care is by breast milk. So, I'm so happy that I could really say something of benefit to the people. And you must have all known, and we have to really practice the whole things, the whole gist of the breastfeeding. I thank you very much for giving me this opportunity. Thank you.
Thank you, madam. Madam, as you rightly said, even after cesarean section, and usually after cesarean section, what happens? The baby is not fed immediately. But we learned from lactation specialist and all that even though it is a cesarean, there is a way to feed the baby from the shoulder side, and we can make the mother feed the baby. So
definitely,
that golden hour or that golden minute also, I can say, is not lost. At least.
Yeah, I think sometime later on, the hour will be converted into minute. Maybe.
Yeah, in fact, when we have the Government of India initiative called as MA, the Mother's Absolute Affection, which recommends delivery of the baby on mother's abdomen, and even before cutting the cord of the baby, you should, attach the baby to the mother's breast, or even the baby can crawl itself towards the breast. So that fast or that urgent, you have to attach the baby so that the baby can learn on its own, and the initiation of breast secretions can start at the earliest. So you are very right that it's not even golden hour, but it's the golden minute. And just a day before yesterday, I was on a program with National IAP and NNF, National Neonatology Forum. So there they had, I had to participate from FOGSI side. So we have various recommendation as far as the policy making. So similarly, we have suggested some labor room bundle, like the pediatricians suggest delayed cord clamping, which all of us are following nowadays, and the immediate skin to skin contact, no unnecessary drying or suction, whatever. It's totally unnecessary as we're talking, and no separation of the mother and baby, breastfeeding as soon as possible, as we just discussed. And we have to observe the effective latch or the deep latch. No schedule or restricted feeding. Rather, it should be a complete unrestricted feeding. And of course, whatever suggestions we have talked about, Madam has already talked about. So only two things I wanted to say about the flat and inverted nipple. Madam has shown the picture. So the flat or inverted nipple doesn't interfere with the breastfeeding, and as she rightly pointed out, there is no need for manual correction. Because the baby attaches to the breast and not to the nipple. That is what is the explanation for that. And for the breast abscess, in fact, when I was a chairperson, we have almost hundreds of patients which we have tackled. Dr. Mangalavani, who is the lactation consultant from our committee, and she also had presented a paper. So they have more than 100 patients who were treated with only needle aspiration, for which you have to use the 16 gauge needle. And if it's a small abscess, even single setting will do. But if it's a larger one, you may have to go for multiple settings. But it is always good, rather than going for IND, you have to even stop breastfeeding, which is actually not the aim. Our aim is to continue the breastfeeding. So definitely, needle aspiration is the way forward, even when the patient has breast abscess. Madam, wonderful listening to you, and thank you, Madam Shikhamani, once again. Yeah.
Thank you very much.
So needle
And Dr.
aspiration
Uday
is
wanted.
done- Yeah, needle aspiration under ultrasound control is needle aspiration under ultrasound control of a breast abscess is the way
Yes.
to go. You know, it prevents,
Yeah,
it
that is
doesn't
the way.
interfere with anything
Yeah.
more. They can even continue breastfeeding is very important. And
Yes.
all breastfeeding today, we are stressing even in our Manyata program, which is a FOGSI program for all the nurses, and we are teaching them all this very well. So lovely lecture, Dr. Modi. Thank you very much. And if I can now introduce Dr. Narendra Malhotra.
Yeah. Good evening, sir. Narendra, sir.
So nice to see Dr.
Thank you,
Narendra
madam.
Malhotra.
Thank
And
you,
he's been in the
madam.
past.
Thank you.
Thank
I
you
don't
very
know.
much.
This is such a
Pranam,
long.
sir.
I'll have to wear my specs to introduce him. But he's got lots of friends on Facebook and he's very active on the social media. And he's a wonderful person, the past president of FOGSI, director of art, Rainbow IVF, director of the FOGSI Smriti Manyata CSE, and vice president of the Society of Ovarian Regeneration. He's into everything ultrasound. He's the director of the Iron Donor School of Ultrasound, and so many more things. And he have all his orations and
Thank you,
and lectures out. No, thank you, Mane. I have to also focus on your topic today, Dr. Malhotra. Dr. Malhotra is going to talk on the probe and the scope, which left me wondering whether he is going to talk about the scope of the ultrasound probe or he is going to talk about the probe which the laparoscope probes and sees. So I don't know what it is about. So I leave it to you, Dr. Narendra, to tell us about the probe and the scope. Over to you.
Yeah.
So very good.
All of us are eager to listen to you, sir.
Very, very good evening to all of you. It's indeed a pleasure always to be in this Guru Mantra of ICOG. It is a scope, Dr. Ujay. One hand is the probe, the other hand is your scope.
Yes.
That is what it should be for the management and diagnosis of not only female infertility, let's show all gynec diseases in women. So these are the two magic wands which every gynecologist should know how to use them, so they get magic out of their diagnosis for their diagnosis. Now, what are the learning objectives for this talk is that we have to understand what the probes are and what are the endoscopes are. And how do you work up a gynec patient, especially the infertility patient? By doing a TVS, using a TVS 3D, by injecting saline, by injecting contrast, by injecting foam, by HICOC, by HSG, and then finally landing up with the scope, which is the hysteroscope and the laparoscope. So this will review the diagnostic accuracy and limitations for each of these modality, and we'll try to translate all these findings which we do with the use of these two wonderful magic wands and base our management and decision on it. Now, we all know that infertility is inability to achieve a clinical pregnancy after 12 months of regular unprotected intercourse. That's the definition now recognized by all, given by ASRM, and it is affecting, I think, even more than 15% now. So the female factor is about 40% and 40% male and 20% combined. So female evaluation is what we are going to deal with today, and we'll leave the male, and that is how we are going to do a targeted imaging so that the time to diagnosis and management planning is shortened. We are not going to linger on, say you get a TVS today, you get your hormones done tomorrow, you get a HCG done next month. So we're not wasting her 1, 2, 3 months for that. So what is the diagnostic practical algorithm which we are going to use? Initial basic evaluation, history, menstrual pattern, semen analysis, ovulation assessment, AMH and AFC. These we need. Now, when the patient comes to us, we call them as a couple. While we talk to them first together, and then when we ask the woman to go and change into the examination room, at the same time we ask the male to go and give a semen sample. And by the time we go to the examination, do a per speculum examination first. Please note a PS. You don't do a PV, I don't mind, but a per speculum examination is a must. And then use our probe, which is in the OPD with us as the transvaginal, to evaluate the cervix, uterus, ovary, and the adnexa. And if you find any diagnosis, diagnose that, or at the same sitting, if she is in the follicular phase or day 6 to day 10, put in a small Foley's or even a feeding tube number 8 through the cervix, which goes in very easily on your examination table, and then do the scan and inject some saline and look at the tubes also. So at one sitting, we have evaluated the vagina, the vulva, the cervix, the uterus for musculature, the uterine cavity when we put saline, the tubes, the ovaries, and everything. So one step complete examination of the patient whenever she lands up into your clinic if she is before ovulation. The role of the scope and laparoscope is selective. Previously, when there was no TVS, we were said that every infertile patient should undergo a laparoscopy. Now we know that the peritoneal factors of infertility are only 10 to 15%, which the laparoscope will pick up additional to the ultrasound. 85% of the problem in female infertility can be picked up by ultrasound. So we are doing 80. If you do take laparoscopy as 100 all infertile patients, you'll be doing unnecessary 85 laparoscopies and subjecting the patient to an operation and anesthesia. So that is out. Ultrasound is the probe is your first stage. Based on all this, we developed our own protocol and we published this. So we divided women into age groups and the duration of infertility. If she's young and a short duration of infertility, by young I mean less than 28 and less than 3 years. If she's more than 28, that is 29 to 35, and infertility is more than 5 years. And the age is more than 35, infertility more than 5 years, or if the age is 40 or with a long-standing infertility. And you will develop a protocol for all these. So unnecessary investigations will be avoided in patients who are over 40, like a laparoscopy and all, and they'll be counseled straight away for IVF or with a third party. So with the young couples, we do the basic test. We do a semen analysis. By the time you have done a probing of the woman, the husband has got the semen, given the semen. One drop on a slide with a cover slip on your OPD table. My microscope is right here. I look myself. If you see multiple sperms which are moving very fast, the detailed semen analysis goes, but you are happy, it's not going to be a male factor. So the baseline scan has to be done. If she's in follicular phase, we are going to evaluate the follicles and the tubes. And if everything is normal, we give her timed intercourse with some fertility diets, supplements, and exercises, etc. So if there is a pathology, then we'll use the scope. The pathology could be in the uterus, in the ovaries, in the tubes, in the cavity, in the cervix. Then only the scope comes in play. If it is older couples, you evaluate the couple and do a complete endocrine testing because we want to know her endocrine status and the ovarian reserve status. And still we will do a tubal patency test if it has not been done or if it was done a long time back. And if indicated, the scope is put in. If not indicated, we plan this patient for an ovulation induction and 3 or 4 cycles of IUI and refer them early to ART because the ovarian reserve is going to run out. So we need to know the female's biological clock, which will keep running out. If the patient is over 40, perimenopausal, irregular periods, short cycles, AMH and AFC become most important. If she has no eggs, if she has a very low AMH, straight away ART and may need third party. And of course, the male factor again. If the pathology like fibroid, adenomyosis, endometrioma, dermoids, anything is detected, then we go ahead and do the laparoscopy, which could be histro and both. So based on this, we say infertility should be managed as an active management. And active management of infertility, single step management, single day management is what we are aiming at with the different age groups. Now here the probe becomes the most important thing. And on the first lining, you see if I'm examining this, if Dr. Mamta Dindyal is there showing us how there is in the cavity a lesion which is very suspicious. And it is right in the cavity. And the homogeneity of the endometrium is also. So this is probably a submucous fibroid there. She will not conceive without the use of a scope. And it has to be removed. So that is what makes you on the first day decide her treatment protocol. If the probe shows a dominant follicle with good color flow, which is about to rupture, shows 2 layers and everything, then she is ovulating and the ovulation induction protocol cannot not to be used only if she needs controlled ovarian hyperstimulation and an IUI. So we are going to do an abdominal ultrasound. We're going to do a TVS. We're going to use the color and the power with a probe. We're going to use saline injection at the same sitting, and we're going to do contrast if you have the contrast or if you want more definitive diagnosis. So the probe will tell us the pathology in the cervix, Nabothians, especially at the internal os, which cannot be seen by perspeculum. It will tell us about the endometrial cavity. It will tell us about the endometrial myometrial junction, which should be healthy. It will tell us about the myometrium equidistance everywhere. It will tell us about fibroids or anything. And then it will tell us by the sliding sign whether there is deep DIE or not, deep infiltrating endometriosis, and there is adhesions or the obliteration of pouch of Douglas. And here, if your probe has a 3D, 1 more minute and a 3D image is captured, and you can get such a beautiful image of the cavity telling you that there are no congenital anomalies of the uterus and the cavity is adequate and it's not a T-shaped uterus or it's not anything else. So the goal of using the probe, as you can see here, is to get it in longitudinal, then cross-section, and then if there is a pathology, then put saline. See, I just put saline here, and I can see this polyp hang out from the posterior wall, and I can put the color on to see whether this polyp has 2 vascular or not. So we're going to confirm the uterine cavity. We're going to confirm the ovary accessibility. We're going to confirm the tubes, hydrosalpinx and all, especially even when we are doing before IVF. So what is saline sonography? Now, saline sonography or sonohistography is introducing a contrast media, which is water or saline, and then evaluating, because saline will appear black, and when it appears black, and this is how it is done. So you schedule it after menstruation, maybe analgesia, maybe not. I'm doing this under anesthesia just to record and show everyone. Anesthesia is not required. It is done on. See now, when you use a Foley's, that other end of Foley's, you need a special syringe to push the saline. Either you have to have a bladder syringe, or we cut the end of the other Foley's and use it as a connector. So inflate the bulb by about 1 ml only, not more, because you don't want to block the cavity. And then use this connector is put on the other side. And now the assistant is ready, and now I'm scanning it. Now, when I'm scanning, I see the Foley's in the uterus. I'll pull it back so it comes near the internal loss or reduce it. I notice there is some fluid in the pouch of Douglas. This is very important because post-procedure fluid is going to increase if the tubes are patent. Then I'll go to the adnexa and look at the ovaries. So I have everything in one scan. When I see the ovaries, it has 2 or 3 follicles and 2 or 3 small ones. So the AFC is good, and one of them follicle is growing. I put
I think we've lost his connection. Maybe he'll be joining again.
Let's just wait for sir to join.
Something happened.
Yeah.
You can see my screen and my slides.
Yes. We can see
So
them
we have
clearly.
Yes,
put
sir,
the
we can
color
see and hear
box
you now.
on the. So we put the color box on the whole screen, and then we are pushing the saline. And if you see a color bruit coming all over the screen, you know it is patent. And after that, when you see that the fluid is increased in there, you can do it with a feeding tube. Now this is good, not a bulb. No bulb is there. And when we use the feeding tube, it might slip out when you push the saline. So we have to do it very carefully. And it is done mainly for polyps or cavity. So we withdraw it. Once we put the fluid, you see there, you can recognize a whole big polyp which is there, or if the cavity is normal like this. So saline sonography for tubal patency and for polyps is very, very important, and the sensitivity and the specificity goes into 90%. So much better than doing a HSG. And HSG, because a woman has to go to a radiologist, go to a dirty clinic, a hard bed for many technicians which are not shaven, body odor, and third doctor comes in, pushes the dye. I'm in a hurry. This you're doing yourself in your clinic. Patient is very comfortable. It has got more accuracy, and you're knowing many more things. You're knowing about the ovary, you're knowing about the fibroid, you're knowing about everything. And so that this is my first line of treatment, which I would suggest. HSG, maybe you'll say it gives you pictures. Yes, it gives you pictures, but with the contrast, you can get the same pictures with SSG also. So we can get pictures like that. This was a normal 2D. When we put saline, the cavity is normal. When we do a 3D or a coronal section, you see the saline. So it's absolutely wonderful pictures of the cavity. Again, suspected endometrial polyp. When you put saline, you see that the polyp is coming from the fundus, and the polyp is coming from the fundus, suspected likely, and this confirms the polyp. You cannot confirm this with the HSG. It will just give you a filling defect. So multiple polyps, 1, 2, 3, 4. Again, with HSG or with the other modalities, it will just say space occupying lesions, or it will say filling defects. Here you can know where the polyps are, how many they are. And when we go ahead and do the hysteroscopy of the same case, as I can show you here, you see they are at the same place what we diagnose. So the accuracy is absolutely over 95%. You see that the upper part here is normal. That's normal. There is a polyp there. There's a polyp here. And then you go ahead and remove it. So after the removal of the polyp, again, you can do a scan and see that the polyp is completely removed. So the probe is used there. Now, if there are fibroids, now the fibroids have to be classified according to the FIGO classification. And here's our friend, Dr. Osama Shaki, showing you how fibroids even the difficult fibroids can be removed. Now, this fibroid, which you can see here, is 50% in the cavity. So this much easily removed, then it comes back. Now, this fibroid is very difficult to remove by the scope, which you can see, and this only the patient was 3 laparotomies. But if your probe tells you exactly where it is, you can go ahead and cut that area if you're very sure. And even if it is intramural a little bit, please don't try this unless you are very experienced. Even if it is intramural a little bit deeper inside, it'll show up. Now, once it shows up, either with the pressure there, you can just pull it out, or you can experimentally put the screw in on the side and pull it out. So that is what was done in this case with the big fibroid. So the scope has a big scope of dealing with difficult myomectomies hysteroscopically also. Otherwise, the laparoscope was not going into this patient. What about intrauterine adhesions? Yes, Asherman is important, and with saline you can diagnose Asherman and then go ahead and treat. What about endometrial diseases? Endometrial hyperplasia, as you can see here, your saline confirms it, and then you go ahead and do a treatment. Polyps, use of 3D. The 3D gives you beautiful pictures like this, exactly how much it is inside and exactly how you have to plan your surgery with your scope. So from saline, we can go to HICOG. Now, when you use HICOG and 3D, see, this is with saline, where you get a color bruit. When you use HICOG and 3D, you can get pictures like that. Now, these pictures are actually like looking at the uterus by the lab, and they're not difficult. You'll say you can get it, we don't get pictures like this. It's not like that. It is a simple procedure, just has a little bit learning curve, and here, which I've shown you here. And with this learning curve, all of us can start doing this in our OPD. Use of contrast, I don't recommend, but if you use it, will come as white. With saline, it is coming as black. Contrast, it comes in white. So contrast, you see this is when we are injecting contrast, how the whole tube can be outlined and the site of block can also be. So that is the advantage. And when you use contrast in 3D, you can tell where the block are and whether it is the block can be opened up or not, or whatever it is. And so ultrasound becomes, or the probe becomes, your first line. Now, if there are hydrosalpingo, the fluid is not giving you a bruit, but it is localized. If it is localized, it's only the fluid is circulating in the hydrosalpingo. Then we stop the fluid, and you see that there is a fusiform swelling which has appeared, which by 3D will look something like that. So these are 3D ultrasound pictures if you have the 3D on that. Tubal blocks can also be managed under ultrasound guidance or by hysteroscopy. Of course, we do cannulation, but with the ultrasound guidance, also we can manage them and put a Janssen-Anderson cannula, which has a memory and turns left, and then keep on injecting saline and look at the tubal end. So selective tubal cannulation or selective tubal patency test can also be done by ultrasound. So our use of the probe on the first visit is vaginal ultrasound. After you've done a clinical examination, saline sonography, sonohysterography, collapse the balloon and look at the HICOG if you require, and then the use of the probe. If you have 3D, the advantage is this. That was 2D picture. This is the 3D picture of the same. So the advantage is planning the surgery. It's not a gimmick. Then all embryo transfers are done under the guidance of the probe. So you have done a TVS, you know the acute angle, and then under ultrasound guidance abdominal probe, you place the ultrasound guided IUI is not required, but people are doing it. And any complications which happens due to pregnancy relations, especially multifetal pregnancy, you again need the probe. We do transvaginal embryo reductions at an early stage, or they can be done transabdominally at the stage of 11 weeks, or the nuchal translucency testing, NT-NB scan. The endometrium, there is no other way to evaluate the endometrial thickness. With the 3D, you get the color. You have to look at the junction, which should be healthy. And if it is not healthy, it is early adenomyosis. If it is adenomyosis, there'll be areas, lines, buds, islands, and stria, which the probe will tell you. Then the uterine receptivity, only the probe can tell you, no other thing. So uterine thickness, uterine layers, uterine color blood flow, especially the perfusion in zone 4 like this. That is all very, very required, because if the color is to zone 4, your pregnancy rate is going to, and the vascularization should change like this. This is day 7, day 9, and the day of HCG or the day of embryo transfer. If something like this is happening to your patient, she's very, very good. And now sometimes it's important to get the volume of the endometrium cavity if it is an adenomyosis. So if it's a very small volume, small uterus, or a large uterus, again the probe 3D will tell you the volume. How about Mullerian agenesis? Previously we used to do HSGs. Today we use the probe. And with the probe, we can classify that as the Escher classification was the latest as U, C, and V. U is uterine anomalies, C is cervical anomalies, and V is vaginal anomalies, which can be done. Now, organ-wise, probe will help you tell the AFC and ovarian pathology. And you should know where to look for the ovaries and how to look for the ovaries, and do a push-pull sign also. This I'm doing the push-pull sign, and you see it slides. When it slides together, there is addition. When it slides over each other, there is no addition. So sliding sign. And we have to know whether this ovary is accessible for IVF pickup or not, and stimulation, how the ovary is going to grow and where it is going to go. Now the follicles may be small, may be large, may be high. Again, we can predict by the number of follicles on day 2 whether they're going to grow. So your baseline scan has to be done on day 2. You rule out all the ovarian anomalies, chocolate cyst, PCO, endometrial shedding, and then go ahead and do the follicle monitoring on day 6. Day 9, they grow and they develop color. And then the endometrium matches with so there is endometrial synchrony. And you plan the HCG. Now, all this has been now coming with the AI. So all machines are doing AI, and automatically they'll tell us all the pictures and calculate and even guide us on HCG timing. Now, if there is ovarian pathology, then we score that adnexal mass or the ovarian pathology by the aorta scoring. And if they are simple cyst, then I go ahead and drain them and put a sclerosing agent in the cyst. We've even tried this for endometriosis cyst. So the recurrence rate or repeat surgeries are not required. Otherwise, endometriomas need surgery if they're very big. But aspiration of endometrioma with sclerosing agent, Ascarol, can be done. Even for hydrosalpinx, we can drain them, inject antibiotic into it, and inject a sclerosing agent. So you save a laparoscopy for just clipping the hydrosalpinx. Endometrioma. Then, of course, the probe is required for all interventional procedures in IVF, like ovum pickup, like embryo transfer, and that is where you have to be there, required there. Now, with uterus cavity, we have told you that uterine anomalies can be required, and then you use your scope to do whatever treatment, like lateral metroplasty, addusolysis, septum correction, septum resection, because we are not resecting the uterus, we're cutting the septum. So resection is probably the wrong term. How do we do it? We do it with the 3D, and we plan our treatment through the 3D probe with the scope in the hand. Now, automatic follicle monitoring is there. Patient can be now given a probe to carry home, and you can monitor them from the hospital. So this is how we can monitor. Unfortunately, in India, this will not be allowed because of the sex determination, but otherwise abdominal probe or vaginal probe is given to the patient, and we can do home monitoring and home stimulation, so she doesn't have to visit and this software and the devices pulse more, or what we call. So the magic sticks for diagnosing and treatment are the scope, the probe, and the scope. And the probe gives you a virtual hysteroscopy picture. See, the uterus cavity is like that. With my probe, I got a picture like that. And when I scoped her, the picture was this. So it is absolutely virtual. Lastly, the vagina has to be also examined. When we put the cusco-speculum, the vaginal wall cannot be seen, because the speculum is, when we put the sim speculum, the posterior wall cannot be seen. So we do vaginoscopy to look at the vagina. And that is using the hysteroscope, putting it gently into the vagina, filling the vagina with fluid, and looking at the vagina. So the speculums are also you can use see, this is the vaginoscopy. And this can be again done as a outpatient procedures. So cervical erosions are seen much better and the fornices are seen much better, and you can go ahead with the Bitochi scope and do it with it. With the probe, the 3D cervix can be seen as good as this. So to conclude, these are all the operative things which we can do with the scope, which I've already told you, and the anomalies which I do. So hysteroscopy, while it is the gold standard for visualizing the cavity, but today 3D with saline is almost the gold standard. And laparoscopy should not be done as only diagnostic, should be kept only for operative procedures if we are diagnosing. The practical tips is use your probe and then use scope. There are going to be some limitations, there are going to be some pitfalls, which with your experience you'll be able to tell. Of course, the future would be that AI would come into it, and a lot of artificial intelligence are going to be used with ultrasound machines to make the diagnosis without even you getting it. So the machine will tell you. So take home message, ladies and gentlemen, is TVS, 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 TVS and ultrasound was the past, is the present, and will always remain the future for any diagnosis of gynec and even obstetrics. We have written some books on this, on step by step. You can go through them. The revised editions are available now, and they're also available in, if you can't read English, in Spanish and Chinese. So you can do that also. Thank you very much. The references to go read more is ASRM and ESHRE guidelines. Thank you, Dr. Sheila, for giving me this opportunity to speak on a topic which I really like.
I think
Thank you.
Uday, beginning
Yeah.
only he said the probe and scope, and then really everybody started thinking that what are we going to listen to you? And I think you really made a justice, as well as Madam also. Madam, that 3 formula and everything, such simple things, but very important, I mean. And Dr. Narendra, we know your expertise. I think almost you are all-rounder. I think most of the things you handle. So that way. And Madam suggested that topic and she did a justice. Madam, I must tell you that milk banks are there now. I think it must be there in Patna also. We also have. But I always feel, that we were lagging in neonatal care in our country. Still, the so much of importance is just not given, because we talk about 1,000 days. So this breastfeeding now, the concept is 24 months. I think we have to really see to it that that message goes to everybody. And I know working women may find, but that rule of 3, what you told was really, I think, will be helpful even for the working women, because they can extract and store the milk, and then the people at home can take care of the baby. That was a very good message as well, Dr. Narendra. Excellent talk. Thank you. Yes,
So
Dr. Uday.
one question for Narendra. When you say that you are going to use a sclerosing agent for treating a hydrosalpinx, one is which is the sclerosing agent you use? How do you decide how much to inject? And aren't you worried that it may go through the os and injure the endometrium?
So very, very good question. A lot of times this is asked me, what sclerosing agent are available are ethanol, that is alcohol. You use this, the patient will wake up drunk if it leaks into the peritoneum, which may be good for you or may not. It doesn't harm her, except she wakes up drunk if you're using alcohol. We are using escarole or spironolactone, which is used by the surgeons. One ampule has 2 ml. We usually, if the cyst is big, we take 2 ampules. With connector, we make a foam of it, and that foam is injected. And what it causes are inflammation of the walls. So once you've drained the hydrosalpinx of the cyst, it has collapsed. Then you are injecting this sclerosing agent will inflame the walls, and the walls get adherent to each other, and recurrence does. Still, we get 20 to 30% recurrence, because some areas the cyst wall is not damaged and it will start filling up again. But escarole, if it leaks into the peritoneal cavity, nothing will happen. Surgeons give it intravenous
I'll call you
also
back. I'll call you back.
for venous this thing. So for veins
Varicose
in the
veins.
leg. So
For varicose
y-
veins.
for varicoceles and all, it has been used. So it's absolutely harmless. Nothing will happen if it leaks into the peritoneum. Alcohol, if it leaves, we just had a talk just two weeks back from a foreigner who's talking about only ethanol, and he also didn't have escarole. So we said we're using this. They in the talk said that patient do wake up with some alcoholic, some grogginess and all.
Thank you so much. Thank you so much for this wonderful lecture and wonderful ideas, and that how to finish off an infertility evaluation in one sitting. It is so important, especially people coming from far. It's really useful. In private practice, it may require a little convincing for the first visit to tell them, we want to push in a dye and all, but maybe in the second sitting, at least, definitely this can be easily done. Thank you so very much for this lovely lectures, both of you, Dr. Modi and Dr. Narendra Malhotra. And thank you, Sheila and Pratik, for this lovely opportunity. Thanks a lot.
Thank you. Pratik, what are thanks?
Thank you, madam. And I'd like to begin by expressing my gratitude to our esteemed faculty today, Dr. Pramila Modi, Dr. Narendra Malhotra. Sir was a little busy in the beginning and he requested Dr. Modi to go first. We thank her for accommodating us and for being with us during this important breastfeeding week. So one activity on breastfeeding promotion ICOG has already done. We await more activities by our governing council members. I see Dr. Kanchan Prasad, Dr. Mitra Saxena, Dr. Anita Rajoria have all logged in. We also have our past chairperson of ICOG, Dr. Lakshmi Srikhande, who was present with us for quite some time. Thank you very much to all of you for joining and for continuing your support to ICOG activities. Also like to express my gratitude to our two chairpersons for today, Dr. Uday Thanawala, our past chairperson of ICOG, and Dr. Sneha Bhoyar, past chair of the Study on Female Breast Committee. Thank you very much for your wonderful inputs. Two fantastic lectures, as I said a little while earlier, by Dr. Pramila Modi and Dr. Narendra Malhotra. Always a treat to listen to sir, and I'm glad that his voice has recovered. We also had the privilege of seeing him yesterday during the ICOG 7th CME. So he's consistently been here with us almost on a daily basis, giving all his time and focus and attention to our ICOG activities. Thank you, Dr. Lakshmi, for being with us. Anything you would like to contribute before we wind up the session? Because
No, I
we've not
just
spoken
logged in
anything
to
from.
listen to both the gurus. Both the
Thank
talks
you.
were
Thank you so
so
much.
apt,
Really
relevant, and fantastic. It's always a pleasure to listen to NM sir, and so nice to meet and greet Dr. Pramila Modi madam. I to just enjoyed.
So there
Thank
was
you, ma'am.
one
So thank you,
question
everybody in
by
the audience.
Pratik. There was one question by Janak Agarwal, but will it close the cavity of the tube? So is it good for us? I think it is similar what I asked about sclerosing the hydrosalpinx.
Correct.
So that I think he must have
This
got
is
his answer that
pre-IVF.
we
Pre-IVF,
have
we
to do
want to
it.
close the cavity. So you do a
Yeah.
laparoscopy
Exactly.
to either do salpingectomy or clip the tube so that the
Yes.
fluid does not.
Correct.
So
Similar to
once we
that.
inject it, we that is our aim. We only use pre-IVF to close in the hydrosalpinx.
Yeah, so that's what I've written as the answer in the chat box,
Yeah.
but I thought let's say it out since there was one question in the chat box. Thank you all very much.
Thank you, everybody. And thanks to our ICOG office staff, Nilima and Pulam. Thank you for all the hard work, coordination behind the scenes. And we look forward to seeing you on Sunday for the ICOG PG training activity, which will be there at 10:30 in the morning. We'll share that flyer and the detailed program with all of you very soon. Hi, Dr. Shishibola.
Thank you.
Thank you for joining in. Nice to see you.
No, I joined
So
and
until
again.
next time, everybody, goodbye.
Dr. Pratik, even I am there. Dr. Tarini. I don't know. I am not able
Tarini,
to
madam,
recover.
your video is not on. That's why I can't
Yeah,
see you.
I am not even able to open, on my video and
It's
to write
You
raining.
comment.
must be in poor network
It's
like me.
raining. Poor network. Yeah.
Yeah, not comment also. Okay.
Thank
Thank you,
Okay,
you.
everyone.
dear
Thank you, Dr.
friends.
Sheila Mane,
Sheila
for
ma'am.
Thank you,
Thank
ma'am.
you.
conceptualizing this
Bye.
program. Bye, everyone.
Bye.
Good. Thank you so much for the nice program. Thank you.
Bye.
Really
Tarini.
enjoyed.
Ma'am.
Hi. Hi. Oh, yeah, after a long Sneha.
Neha
Good
is
to see
there.
you.
Yes.
Good to see you.
Me.
Yeah. Bye-bye. Bye.
Bye,
I
dear.
can
Bye.
see Charu. Yeah, Charu Mittal.
Happy
Yes.